also need to be done, but that doesn't say that, because you travel in the train and an accident is killing so many, why travel in the train? We start walking again, which may be a very healthy option, but it will take ages and we will accomplish very little, because we may go to 1 or 2 towns. So this is true for ICUs. You provide life-supporting therapies with ventilator, with all kind of dialysis. Every system is supported now, so that buys you time. Polio was killing so many, and that's how the ventilator came in. And ventilator didn't kill as many as the polio was leaving disabled and dead. So we have no reason to think that way. And when we say open ICU design is not an ICU in general ward. It's like an ICU which is laid like a general ward, where you don't have separate cubicles for each patient, so that you can have a look at all the patients. But basically, life-supporting therapies are given to everyone there, and that's why they are under that one roof. People with expertise and equipment can help them.
Also, see, purely from the infection control point of view, open ICU is a bad idea, because the nurses will touch each other's and the transmission. That's how Acinetobacter is so rampant in our environment.
You see, I want to say that actually mortality in intensive care has come down over the last 20 years. If you look at ARDS, which used to be 40% in the 90s, is today less than 30%, right? Septic shock and sepsis, at the turn of this millennium, used to be 35-40%, because in the control arm of the Zygris study, it was 35%. Now, in the control arm, it is 27%. In the studies that we got, all these ARISE and the trilogy, the septic shock trilogy, they've all had mortalities in the early 20s from sepsis and septic shock. So it is not that an ICU environment is creating mortality. ICU environment can be less threatening and more beneficial if we take care of all these bits that we are talking about. We have to talk about how we have talked about protective lung ventilation, which has made a huge difference. Now, we should also talk about protective environment, which will prevent infections. So then we can achieve this target. Now, there are risk factors which impact on this protective environment. The risk factors we have to look at. We look at the cross transmissions we have seen, and we know the methods. But antibiotic consumption and antibiotic exposure is a huge problem which other countries, many of the advanced countries, have addressed very intelligently. In Denmark, when they found resistant bacteria, they actually did restriction.
So, what we understand, there is a lack of treatment option to control inflammatory and coagulative pathway. In past, there has been trial with so many anti-inflammatory and anticoagulant. Like best one is the activated protein C, like Zygris. All of those drugs has been failed. At present, there are some benefit, not conclusive benefit, but some benefit to get by time. They are getting with some of the filters, like polymyxin B filter, which just control inflammatory. But does it really improve the outcome? If we talk about the hard data, we don't have. Individual experience are there, that transiently it gives us time to salvage the patient. Which ulonistatin, which Dr. Mehta will talk in detail, which is working at different pathways to control inflammatory and coagulative pathway. We have some evidence, but still we have to go a long way to really conclude that yes, ulonistatin should come as a guide to control anti-inflammatory pathway to treat sepsis. Immunoglobulin has failed in general. It has got very specific indication. If you are dealing with toxic shock syndrome like condition, that's the only time where it works. Otherwise, immunoglobulin do not have any role. So most of the anti-inflammatory treatment has failed to improve the outcome. So, if we talk about the mechanism through pathogenesis which needs to be controlled, we need a product, because ultimately, why we failed initially? Because the product about the anti-inflammatory molecule which has been launched initially, they targeted one specific receptor, one specific anti-inflammatory marker. While sepsis itself is a dynamic process. It starts simultaneously. It starts pro-coagulatory pathway also, it starts pro-inflammatory pathway also, it starts activation pathway also, it starts complement pathway also. So we need a molecule which should be able to control all the process in total. There is an article in Nature which was here, probably it has missed, I'll mention, which has said that why we failed to improve the primary or tertiary level of study, the pilot study of first phase and phase 2 trial, which has shown success. Why they failed in clinical scenario? The one reason has been quoted that there is multifactorial and multi-mechanism pathway in sepsis. They have compared this with myocardial infarction. The results in myocardial infarction is excellent because you can diagnose it early. There is one pathway that coronaries are blocked. You just open it up, you get perfusion and you get result. While same thing do not happen in sepsis. The reason behind that is the dynamic, multifactorial and multi-level pathway. So we need that kind of molecule. So I just discussed all these things in general. Now, the adjuvant therapy which we are going to, like immunomodulator which we are going to talk about, when it has to be started. One of the biggest difficulty for us in treating septic patients has been that we have failed to recognize that in which stage this patient is. We do not have a definite marker which can tell us that this here it is predominantly inflammatory pathway activated, here it is predominantly coagulation pathway activated, or here both are activated. And if it is activated, which receptor level it is working. And that has been one of the biggest limitations, that whatever molecule has been developed, what they did, they blocked one pathway and they did more harm by causing activation of alternate pathway. So we are really not aware about what is the ideal time to start those immunomodulators and which to target. So I will just conclude that although we know that in sepsis we fail to improve outcome because of the activation of coagulatory and inflammatory pathway, more than 176 molecules has been tried in past to control this inflammatory and coagulatory pathway, and most hyped molecule was activated protein C, which also failed and got out of the market. Right now, there are 2-3 molecules on which we are working a little bit. One of them is ulnastatin, one is the polymyxin B filter, and third one is even steroid also does by controlling inflammatory pathway. But we are still far away from getting a conclusive remark that yes, by using this molecule, this will really turn around the outcome in sepsis. Until we get that level, probably we will not be able to change sepsis outcome too much. Thank you. If you have any question?
I was here last year during the same time period, and I'm really happy to be in Gujarat because it's next to my state, Rajasthan. Siroi is the place from where I come, and I always enjoy coming here because I can enjoy some Gujarati food. So that's the message for Dr. Mishra for this evening. This is PGI where I work, and this is the pediatric center that is I look after as the chairperson. Now when we talk about sepsis, I think this is very apt to remember that when we talk about outcome of sepsis, which Dr. Mishra said, we should not expect anything less than what can be achieved anywhere in the world. If you go by this saying of Dr. Sir William Osler, that medicine is the only worldwide profession following everywhere the same methods, actuated by the same ambition and pursuing the same end. The homogeneity, which is most characteristic of feature of this profession, is not shared by any other, including law, church, religion, anything. And therefore, when we talk about should be expecting as good an outcome as it is possible anywhere in the world. But are we able to achieve that in India? This is INDICAP's study, and from that I have just brought the data that mortality in sepsis patient few years ago was 42.2%, and every fourth patient in ICU who contracted this died. And this is the data from Calcutta by Dr. Todi, who again showed similarly very high mortality in a large cohort of patients, almost 60%. I think we have come a little bit down from there, but in pediatric also, if you see this last year data, from Rohtak, 60% of mortality almost. It is not that mortality are high in India. This is data from Brazil, and I just want to console you that although it is high here, but we are not very different from some of other developing countries. And this is about children. Upper one is, sorry. Is the pointer up there? The upper one is trend of the hospital admission, and you can see the parallel to that is the hospital mortality. The absolute numbers have come down. Okay. So here you can see the number of patients with sepsis have come down with years, so also the overall number of patients. But if you look at the hospital mortality, over the years it has stayed around 20-25%, and whether it's boys, girls, across the age group, it almost remains the same. So why it is so? And that should actually make us think in a bigger picture. We are all talking about treating patients with this molecule, that molecule, but how many of those patients are able to get that treatment? So yes, there is a clinical issue, but the bigger issues are political, economic, and social. And it is very aptly said, most health problems are caused not by health issues as such, but by social, political, and economic conditions that drives our lives. There are so many patients in this country who has unique etiology of sepsis. When we apply sepsis guidelines to these, we may not be applying that exactly what is needed for us. So we need to adapt. Low immunization coverage, very high rate of comorbidity, and I'll come to that, how it affects, especially malnutrition, so more so in children, and very high rate of infections. Overuse of and inappropriate use of antibiotics, you've heard, and delays in recognition. We say early recognition, but where is the early recognition? If the patient comes to you early, or even if they come, how many of our colleagues would make a straightaway diagnosis of severe sepsis and shock? Because of lack of training, because of lack of such exposure, or persistence. And then when we do it, we still do not follow the full protocols. We have these guidelines, but we are not following them. This is mortality in relation to comorbidity, just one factor, malnutrition. You can see that as the weight goes down, the mortality goes high and high. And this is across all over the world, whether it's India, Nepal, Sudan, Africa, Brazil, anywhere. And this is the latest data from Sprout study, in which 127 ICUs all over the world participated from 28 countries, from all the 5 continents. In this you can see one thing very clear, that is the mortality with comorbidities is much higher as the age goes. And this is precisely in the adult population when the comorbidities are there, the sepsis mortality is going to be high. So there are some limitations. When we say outcomes are not good, there are limitations that we have. But poor care-seeking behavior and poor access to health care, long distances, transport. Today I was mentioning to Dr. Anil, 1 million people die in this country every year just because they do not have access or they have inadequate health care. Now we may talk about giving good care to the patients that come to us, but overall improvement in the outcome would require that kind of political and economic layout. We still have emphasis on many other things, but the health infrastructure is still infested by shortage of the staff, poorly regulated and managed health sector, and the diseases that occur in our setup, the low resources. There is not much research. You would have continuing research on the small molecules, rare diseases, but diseases that kill thousands, like dengue, Japanese encephalitis. There's hardly anything that has come in all these years. And then on top of it, only few of us stay here. Many of our colleagues are gone to shores abroad because they are being paid well, and that is what has been labeled by President of British Medical Association as the poaching. They themselves know what they are doing. Even today there was a news item. United States is facilitating visas for Indian doctors to come so that their healthcare can be managed. We have only one doctor for every 24,000. They have one doctor for every 6,000. They have 4 times more doctors than us per thousand of population, but still, they can pay more, so we go there. And in these setups, the political barriers therefore are very important, and unless we do something about it, the outcomes may not come down. You would be all thinking that, I'm talking about like a politician, but I think till such time that we take up these calls for advocacy, for treatment of our patients, and improving health infrastructure, we can continue to debate 10 years from now that why the sepsis outcomes has not improved in this country. Because there are limitations to what you can do for your patient. Patients who come to you do very well. Patients who don't come to you. Patients who can't get to a doctor like you, what about them? This is about wealth distribution and health distribution. And you can see that wealth and health, they go hand in hand. So till such time that we have prosperity. If you look at this map, upper one is actually about child mortality, and the lower one is about the wealth. And you can see the balloons, big ones in the mortality, and shrunken ones when it comes to wealth. Ballooning of wealth and shrunken mortality. So this correlation goes until such time that we talk about prosperity, improved infrastructure, and all of this, we will never be able to improve beyond a certain limit. And this is global data on GDP versus sepsis mortality. And you can see that as the GDP goes, the percentage of GDP expenditure goes up, the survivals go up. Okay, so we come back to our clinical, what we do at our level. These were the kind of things that I thought we should all be aware. You have seen this algorithm or these steps in the previous presentation. Are we really able to do it? Early recognition, this goal-directed therapy. We all believe that even the patients who come to us, we may not be able to do some of these things, but we think that we do most of the things. And it is true that if you do all of these things, the mortality goes down simply because using fluid and antibiotics have been able to reduce mortality with sepsis in Thai children by 60%. In Kenya, the mortality came down even to 1 to 4%. and in dengue shock syndrome mortality of 1% and less. Reduction in mortality from 40 to 12% in Sao Paulo or in Brazil when you used antibiotics, fluid, inotropes, mechanical ventilation, all that were available. So when resources are available, mortality comes down. And what we do not have are the resources, or we are not making much effort for that. If we are able to follow the guidelines, the mortality come down. It's again shown in this study in children. So are we really getting to the goals? A study not in India, none actually like this is available from India, whether pediatric or co-adult. But this is a study from one developing country where lack of vascular access, when the patient comes to put an IV is not easy and intraosseous has not been taught. Early signs of shock are not known, which although listed by WHO even for the health worker, the cold extremities, poor palpable pulse in a child, in a patient who is febrile. No measurement of blood pressure even coming in. But even those signs are often missed, and they may be over-treated or under-treated. Of course, shortage of healthcare providers, non-use of goals, and non-compliance, and which is not only in developing countries. The lower one, actually, I have mentioned is from UK. Just 6 years ago, they were still not, although everyone felt that they are doing it, but when you document it, only 62% of the patients had that followed the algorithm. And in fact, it is very interesting. All of us believe that we follow the guidelines. But when this study was done in German ICUs, and I'm sure we are no better, we may be only worse, that 80% or so thought that they are following the guidelines in total. But the actual follow-up of guidelines was only 16%. Check it for yourself. This may be happening also in your ICUs. Fluid may have been given in all right, the amount wise, but it might not have been given the desired time. Antibiotic was given but may not have been given in time. Appropriateness of antibiotic may be missing. And all this is important for us. And also the continuous information and knowledge. Because we know that this is good. Based on those quality of evidence, etc., we have guidelines, knowledge. We process it, we teach it. We expect that people will act on it and act well, but that doesn't happen. So what we need to do is transfer the knowledge continuously and then keep on asking, can it work? Is it really feasible? And then check whether it's improving the survival and quality of life. So in managing shock, besides knowing what is to be done, it's a timing, intensity, duration, and variability. And timing is one which really worries me most in this country, because if you look at this, patient receiving all the care at base level, then they need care in an ICU. Patient is being transported, and early goal-directed resuscitation is needed. Patient is brought from 30 kilometers or 50 kilometers from here, 2 hours, 1 hour in arranging and sending the patient to your ICU. What happens during that time? There is hardly any goal-directed resuscitation during that time. And so what we need, if this is the kind of transport we do not expect any improved outcome, someone who can manage the patient while the patient is on its way to a higher center like yours. Till such time, we are unlikely to improve. So we have to invest at least on good transport and transport teams if we want to improve the outcomes. This is revealing data, and in fact, I would add to it that at my center, of all patients that are brought, all children that who are brought to emergency, 2% of them die on their way. They do not even reach hospital alive. And 24% of all deaths that occur in our emergency unit is of patients who are brought dead. So this is the abysmal state of the transport, and we need to really work on this outside of our four walls and double doors. So we need to fill up this gap, training, transport, and especially while they are being stabilized and being transported. Then only this early antibiotic therapy can help. I'm sure most of you are aware about this data from Dr. Anand Kumar, which showed that every hour's delay keeps on doubling the mortality if antibiotics are not administered to a patient with sepsis. And if this does it, I'll briefly summarize what Dr. Mishra has earlier said, that if we give it in time, the infection load, if we don't give it in time, the infection load has already gone up. Toxic burden, inflammatory response, and injury would set in them. There is no way. So if you give antibiotics when there is already peak infectious load, it won't make any difference whether you use appropriate or inappropriate. It is only the timely, before the infection load has increased, you can reduce all of this, the inflammatory response and the organ dysfunction. And this is where it is so important to know what exactly should be the early empiric antibiotic. And we do not even, I won't say for everyone, but many of us don't even send a culture. In these dates and days,